Assalamu alaikum everyone. I am Dr. Mariam Hassan from Shaukat Memorial Cancer Hospital and Research Center. I welcome you all to the annual Shaukat Cancer Symposium and welcome you warmly at the bioethics session for the symposium this year. So this year we'll be focusing on the ethical issues that arise during healthcare provision and research during public health emergencies. We plan to specially highlight the issues that are faced by lower middle income countries because we have a unique healthcare challenges and we have our own socioeconomic realities, and then our public health needs and population structures also differ from other higher income countries. We also plan to discuss the impact of COVID-19 on global health, and particularly non-communicable diseases such as cancer. We know that research is actually an integral part of an effective outbreak response, and infectious disease outbreaks require that in order for the response to that outbreak to be effective, research is integrated as part of the outbreak response. And this requires a careful balance of time and resources, which are already very scarce in this situation. And healthcare in research in such situation also is faced with unique ethical challenges. We hope to focus on all these issues today, and we hope to generate some interesting discussion for all of you who have joined us. So we'll start off with a few brief talks, starting off with Dr. Nida Wahid Bashir, who's a consultant surgeon at Ziauddin University Hospital. She's also a bioethicist and part of associate faculty at Center of Biomedical Ethics and Culture at Sindh Institute of Urology and Transplantation in Karachi, which is one of the only dedicated bioethics teaching centers in Pakistan. So I welcome you, Dr. Nida, and we can start with your presentation.
Thank you, Dr. Mariam. One thing that I would, a disclaimer is that I'm not a bioethicist. As Dr. Mausam says, we are not bioethicists. We are just clinicians with interest in bioethics. I'm going to share my slides so that we can start the presentation, right?
Yes, please.
Yeah. So the task that had been given to me is about, hold on for a second, just a slideshow. Because, yeah. So what I'm going to do is basically explore ethical challenges in clinical decision making in COVID-19 pandemic in Pakistan. What I'm going to begin with is an overview of the situation in Pakistan. So Pakistan, public health is really a foreign agenda, often taken as a foreign agenda. So if you look at various drives like polio drive, the contraceptive pills drive, the Green Star, or even the family planning in general, it is taken as if a foreign agenda is associated with it. So there is a general lack of trust and community engagement in the process of public health. We do not have the community being the part of delivery of public health in Pakistan, except the situation of lady health visitors and similars all over Pakistan, where there is the community members are actually contributing to the healthcare. That is the only model probably that represents the community engagement in public health. Otherwise, we do not have it, and it's usually taken as a foreign agenda. Uh, Currently, in COVID-19 situation, we had seen that economics, religion, and culture kind of became barriers to preventive measures for a little while, because economics, religion, and culture have different perspective in different social strata. And again, the lack of trust actually translate into a different situation, in a different meaning. Very important thing about Pakistan ground reality is that 60 to 70% is of the healthcare is out of pocket. So it is different from other, as Mariam was putting it, in higher earning countries, because there's a system of healthcare. The government has the responsibility of delivery of healthcare to most of the population. Here, 60-70% of the healthcare is out of pocket. So even in COVID-19, the private institutions were admitting patients with COVID-19 and the person had to pay out of pocket. And considering that the care would be better in a private institution, the preference was a private institution in most of the cities. There was a strong government response for sure, but there was a norm of profiteering happening within the healthcare per se in general, which is a norm in Pakistan. Along with that, COVID-19 just helped the profiteering process, and there was a disparity, and there is a disparity in health in access to healthcare in general. Another important component to understand when we're talking about public health emergencies or pandemics is that the decision making is not the person is not as autonomous that as is taken the world over. Here, the decision maker is often only the clinician, which is a very authoritarian and paternalistic viewpoint. The patient is, if need be, the patient is taken into the decision making. But in our situation, it is the family which comes in before the patient in this end of life decision making often. So we are looking at a scenario which has complexity of its own, and where the healthcare is fragmented in its delivery already. So we did face a lot of issues while we were providing COVID-19 care, and a lot of ethical issues came out of the situation. Contact tracing was one where the healthcare institutions were releasing the list of patients to different sources, and the confidentiality and privacy became a major issue in that scenario. The preventive measures were initially tried to be enforced, but can they really be enforced? With the diagnosis being in public, the role of stigma and the response of society to that patient became a major issue. And there was the vocabulary that was being used is something that Pakistani as a nation does not really buy into. So talking about lockdown, talking about quarantine, talking about isolation, this is not how we live our lives. So it was a major issue. Still, the isolation is a major issue because we live within the families, we live within the groups, and we prefer doing that. So isolation, quarantine, lockdown are the concepts that are not in the vocabulary of people in Pakistan. The trust issue is a major issue, which often you keep hearing, is COVID-19 really there or not? Probably that's a scenario for the rest of the world also. But in Pakistan, we did face denial as one of the major issues, where the existence of the disease and ability of healthcare institutions to provide the care was being challenged often. And economics did govern our decisions. Somehow or the other, God had been kind to us, or the disease had been milder in our situation. We were able to survive through these economic challenges and opening up our country. And others have also learned from us probably. The religion and culture did play a role, but I think it was a very good response in terms of having a dialogue around it. And that dialogue actually helped build up a little bit of trust that happened in COVID-19. So these were the scenario, the way we were operating in Pakistan in COVID-19. The reality of pandemics is that in normal practice, you keep patients' best interest in purview. So whatever decisions you're taking for patients. And the prime interest is the best interest of the patient. But in current pandemic and in pandemics in general, there is a larger interest, which is public health. And if you look at the ethics of public health, it goes outside the autonomy that we're usually talking about. So we need to put autonomy to a side and think of larger public interest. And that's the situation, that's the reality of pandemic. And in countries like ours, where already healthcare is limited, healthcare resources are limited, the prioritization of those limited resources became essential. So in that scenario, when we looked at various guidelines and looking at the the literature that was coming out of the countries which were facing the pandemics before us, we did see a different kind of recommendations, and we sat down and started thinking about it. What should be the recommendation for our scenario? So, if you look at the ethical framework of disaster, it focuses on protecting lives and health, respecting human rights, talks about social justice, and also thinks about building civic capacity so that communities can be resilient in the response and recovery. But were we able to do so, and were there methods or guidelines available to do so with the variables that we have at hand? Here you have to really look at the scenario, the position of a healthcare provider in Pakistan also. So with all those difficulties and access to healthcare provider also faces a similar kind of difficulties. So not everywhere the healthcare provider has an access and is compensated for or reimbursed for the money that they spend on their own health. So, and also the pay structure that these healthcare providers have, and when I'm talking about healthcare providers, I'm talking about everybody from the housekeeping staff to the administrator or managers. They all are healthcare providers. The kind of money they get, was it ever enough to support their own family and their own health or not? So when we start thinking about the guidelines for COVID-19 in Pakistan, CBEC did this job of joining hands with the government and putting out the guidelines that for healthcare, ethical healthcare decision making in Pakistan. So the CBEC composed these guidelines with the help of its own faculty, and involved the stakeholders, international and national stakeholders, in getting the input about the structured guidelines that they came up with. What I'm going to do is share a few prominent features of these guidelines and what the thought process was in these guidelines. So aim of these guidelines was to provide an ethical framework for institutions and physicians to formulate standard operating procedure that will maximize benefit to the public while minimizing risk to the healthcare provider. And the risk to the healthcare provider was a major issue when we started with COVID-19, because the personal protective equipment was nobody's responsibility to begin with. And then with the passage of time, we geared up, and still in a lot of places, the personal protective equipment is still a healthcare provider buying in from their own pockets. So the minimizing the risk to healthcare provider was a major issue. And if you can look at the numbers and of around COVID-19, you see a large number of healthcare providers going down, having COVID-19 or dying of COVID-19. So there is the risk is really substantial. And it was so all over the world, but here our access and provision of healthcare for healthcare provider is also questionable in our situation. So prime values that were considered within these guidelines were equity. That means, as the objective have clearly said, making the access easier, making it easier for the public to access the healthcare that is required, and also reducing risk. And this, as we have already pointed out, that equity becomes a problem where access to healthcare is linked to out-of-pocket payment. So does everybody have an access to same kind of healthcare? So equity becomes a major issue, and an effort needs to be made in that direction. An effort needs to be made, and although government did make quite a significant effort in this area, but equity was a prime concern that we did consider very important when we were talking about the guidelines of ethical healthcare delivery in COVID-19. Utility was the second one. So utility is also in terms of resources as well as the patients who were being prioritized for settings. So prioritizing the worst off utility was a major component that was being considered there. Reciprocity of which is towards the healthcare workers. And this guidelines very clearly emphasized that healthcare workers should have an access to healthcare within their institution if they fall ill, and should be prioritized if they come into the emergencies of their. If you look at the healthcare worker, a person who is going back to the house, to the family members, with enough of the risk of carrying the disease back home, and one of the family members is ill, and there's no bed available. There was a time in Karachi when beds were not available for people to get admitted. So these guidelines did propose that under the principle of reciprocity, healthcare workers and their families need a bit of prioritization, need to be facilitated while providing healthcare. When you come to the prioritizing worst off, the guidelines clearly said that the first come first serve cannot be the rule, because in that situation you will be missing those who really need your help. So the criteria of the prioritizing worst off is probably the better idea, and doing a triage is what is going to facilitate this process. So, and in case you have two equal cases, the random allocation is probably what is going to help in that situation. So guidelines clearly recommended that first come first serve is not the idea that should be entertained as a principle when you're coming to the allocation of bed and resources within the healthcare institution. A big question that was being raised throughout the thing: who gets the ventilator? And various variables which were being considered at that time were age, extent of the disease, other coexisting conditions, life years saved, and if all is equal, then toss of a coin. What was clearly said in the guidelines is that age does have a significant effect of COVID-19, but that cannot be the excluding criteria for those above 60. It will be inappropriate because not all more than 60 are going to die of COVID. And it cannot exclude population while the capacity is still available. So you cannot be taking age as a solid criteria, as the only criteria to not to provide care to the people. Contributors in provision of ventilators was that healthcare workers and their immediate family, as I've already discussed, need to be prioritized when it comes to the resources that we are looking at. And if the less of the resources available, then prioritizing healthcare workers is probably what we have to be looking at. The one thing that was because of the lack of trust within the healthcare system, a lot of blame game happened around COVID-19. And a lot of time, the clinicians were blamed for deaths of individuals, and they were blamed that they were doing so to gain some money from foreign funds or foreign resources. So when you're looking at individuals who are otherwise not protected and they're taking difficult decisions, they need support. So a recommendation in these guidelines was an indemnity for COVID decisions. So if you're deciding that this person will not benefit from ventilator and should not be prioritized for ventilation, the indemnity of this decision has to come up from somewhere. But this decision cannot be taken by the physician standing in the emergency alone. And if you go further in these guidelines, we'll be discussing that the provision of committees within the institutions was recommended. And also the need of mental health support for healthcare workers, because the kind of stress they were facing with all this was also emphasized. So setting limits is in case you have a situation where the person is in a need of ventilator and is worsening, then when would you do a DNR? When would you decide to withhold care? When would you decide to withdrawal of care? So clearly, when there's obvious futility with severe disease, a clinician can decide, but this decision cannot be by the clinician on the face of it. There has to be a support system available within the institution, that's what the guidelines definitely recommended. The withdrawal of care could be because of limited space or equipment, or severity of pandemic itself can force us to withdrawal of care. But you have to fulfill these are criteria to really decide for withdrawal of care. But withdrawal of treatment does not mean withdrawal of care. That is, provision of compassionate comfort care should not be abandoned was a point that was strongly recommended. In a situation where the healthcare workers manpower is already scarce, there are not enough numbers available, you often find situations when you say the person is DNR, the person is abandoned. Nobody even looks at that patient, and this point has to be highlighted. This point had to be brought forward, that DNR or not giving the treatment does not mean that this person can be in misery or pain. So this for looking at our scenario, this was very important for us to call for a compassionate comfort care for those who are not being offered treatment. So the matter of trust was the prime concern when we were providing COVID care, which seems to be providing in the near future also. So transparency, inclusiveness, consistency, and accountability was something that the guidelines were looking out for. So need of a committee ensuring all of the above is essential, preferably involving those not involved in routine care of those patients. So an institution can, depending on its own resources, its own manpower, its own available possibilities, can form a committee and can form their own guidelines on the basis of which they decide who will come in, who will be getting the ventilator, who will decide who gets the ventilator, and when it is the time to withdraw the care, what will be the process of decision making. And in all that, the family, which is a very important component of the decision making, has to be involved. So guidance strongly recommended a communication at the time of admission and at the time of decision making with the family. In our situation where we are paternalistic, we are authoritarian in healthcare delivery, it needed to be emphasized that immediate family has to be consulted. Whenever the person is getting ICU admission and there's a possibility of withdrawal, it has to be verbalized at the time of admission. And that has to be clearly documented in patient records. So challenges that we as a society face are of trust, misconceptions, not just about the treatment, but also, as we are seeing, the process of the multiple types of treatment that were available to us. And the plasma was one of them, that plasma will cure the disease. So there were a lot of misconceptions within the community about the disease and the treatment. It was a situation of despair. I hope it does not become a situation of despair again. It was a situation of despair where dying, when whatever is available needs to be provided. And this stigma, the religious and cultural norms, especially even today, we see, today when I was coming on my way to this place, I saw two law enforcing agencies, people buying books from a stall where nobody was wearing a mask. So in our culture, it's not considered very humble or very nice if you tell somebody, please pull up your mask, you have to be wearing the mask properly. So our cultural norms are such that provides us a major challenge. And within our healthcare system, equity as a major questionable thing. So what these guidelines did recommend, whatever we thought was the best for us in that particular scenario, but what we have to look out for is that what are we learning from COVID-19 and things that we saw. Are we going to learn from it and devise a plan for next such situations? And how are we going to beef up our public health provision to the community, to society? So in conclusion, ethical challenges faced during COVID-19 have given a real reality check to the status of public health in Pakistan and the world. Pandemics are always a challenge to every person, I think with a big, so there's between the black and white of the society, there's a big patch of gray. And that's where we need to be working around. And the trust is majorly challenged in this big patch of gray. So communication and involvement of community tries to patch up this gray. And within our society, we saw that science was encountering culture and religion in a very difficult terrain. And it emphasized the need of a constant dialogue with the community for such situations. Thank you.
Thank you, Dr. Nida. If you could, okay, you have stopped sharing your video as well. Thank you very much for a very insightful presentation. And I think you have made some very interesting points about, the role of context while any kind of decision making is being made during a public health emergency, especially, and it's within the context you have mentioned that it's not just the resources for healthcare infrastructure that matter. It's also the culture and religion and the societal fabric that matters a lot. A very important point that you made in your presentation was the role of value systems because it's important that equity and transparency is ensured while any decision making is made. A knee-jerk reflex in pandemics is to just do it. But it's important to pause and reflect on all the decisions that are being made because human lives are at stake, even more so than they are in our usual, situation. You talked a lot about trust and community engagement as well. So I think that this is something that we will highlight in our discussion. But since we plan to also capture how COVID-19 impacted global health, I think it would be really good if we can take some comments at this point in time from Professor Bushra Shirazi, because she was somebody who was involved in cancer care during this time. So taking from your presentation, if she could briefly share her comments on how these values were affected during the last 6 or 8 months of the pandemic. I would also briefly introduce Dr. Bushra here first. And I know I've put you on the spot here, but I think that it was really important that we linked Dr. Nida's presentation with some of the, on the ground comments right now. So Dr. Bushra Shirazi is a professor of surgery. She's working as a breast consultant at SIUT Karachi. She's a member faculty at Center of Biomedical Ethics and Culture. She has a long-standing affiliation with various ethical, activities. She is a member of the IRB at Zawuddin University for more than a decade and has also joined recently as an IRB member of the Dai University of Health Sciences. And she has been involved in development of bioethics curricula for both local and international programs. And of course, she has presented several papers nationally and internationally. So Dr. Bushra, over to you.
Okay, so I'd say thank you for putting me on the spot. But having said that, it's interesting to hear this or be a part of the seminar, which is going to be talking about research and it's talking about guidelines and it's talking about health policies. I always find it fascinating because at the end of the day, in a low income country, where does a patient play? Where is that stakeholder? And when COVID came in as an institute that preempted the problems that were going to come up, we did start developing a methodology on how we would approach the pandemic when it came. So we started making a structure for when we would be hit by the pandemic in a larger scale. However, the things that do not tie in when somebody is developing guidelines or when someone is developing a disaster plan is what happens to that individual who is not affected by that pandemic in a direct sense. So there are people coming from SIUT, there are people who have dialysis. Dialysis doesn't stop when a pandemic happens. Or somebody who has cancer, the question arises is the chances of an individual being struck by COVID versus the cancer that they know they have. These are issues that are never really addressed or made a part of any plan, any framework. So the framework is looking at an issue in isolation and looking at the stakeholders within that disaster that they are planning against, right? However, what happens to the individual who is not really a direct stakeholder of this isolated issue that is being looked at? So I find that very interesting and raising a lot of questions on when research policies or health policies are made, it does not actually impact medical treatment as such. And at the end of the day, when you're talking about a healthcare professional, the aim is to treat someone who is in a compromised state of health, be that an infectious issue or be that, a cancer issue. So when we saw this at our institute, so yes, everyone was learning on their feet, and I think that leverage has to be given to, the whole healthcare system. Nobody knew what was going to happen. Nobody knew how to treat. But what we landed up doing is we continued part of the clinical practice that was going on. So for cancer patients, we just continued going on for giving those who are in the middle of chemotherapy. We did continue giving chemotherapy. Guidelines came up regarding cancer management. So people who were hormone positive, we could buy some time on, 4 to 8 weeks. So yes, we did have this blackout period of no surgeries till protocols and guidelines could be developed as how to move forward. It did impact them. The fears of the patients came up right in front, because when somebody knows they are living with a cancer, each day is like a year for them. So whatever you really talk about that this issue is going on somewhere at an individual level, which even Dr. Nida mentioned, the autonomy of that individual or the empowerment of that individual is compromised because of this public health that kind of is taken, precedence over it happens. And as a clinician, when you're out there in the field, it doesn't give you the best feeling. And even if science tells you that, giving a hormone therapy, for example, will not drastically change the outcome if they get it, for example, for a period of 3 months. But in a country where literacy and understanding, and at the end of the day, the patient is reliant on the doctor for technical decision making, there's a feeling of insecurity there. And that is why being, out there with patients all the time, I find frameworks and guidelines very helpful at one level, but at another level, they really hinder and do not really look at the patient. They are not out there. They're not out there to tell somebody who comes to the gate that, no, we can't treat you. So for me, it does give you a lot of moral discomfort, because I distinctly remember a patient coming and saying, But Dr. Saab, I have the cancer, I don't have the COVID. So why is my treatment being delayed? You know, so those are the things which I think guidelines, however well they are made, they address a problem in isolation. And that is how I would generally critique most things like this that happen.
Thank you so much, Professor Bushra. I think Professor Bushra had made a very interesting point, which is the disconnect between guidelines and what happens on the ground. And because it's the physician that is making the difficult decision of refusing care to a patient, however temporarily it may be, it does put them in a lot of moral discomfort. We have two very interesting questions in the chat here. But I think what we will do is that we will, bullet through the presentations first, and then we can take these questions during our panel discussion, if that's okay with everyone. So we will move to the next part of our presentations, where we switch gears from healthcare provision to research. In this section, we have two very interesting presentations. We'll start off with Dr. Nandani Kumar, who is the former Deputy Director of Indian Council of Medical Research and the Vice President for Forum for Ethical Committees in India. She's somebody who has been involved in clinical pathology and basic sciences, but has been involved extensively in guideline and policy making and in bioethical activities. And we hope to benefit greatly from her experience today. Dr. Nandini, over to you.
Okay. First of all, I must thank Dr. Mariam and the organizers for inviting me to this talk. And as a result of that, I can meet some associates like Amir and Nida, whom I had met several years ago. And thanks for that opportunity. Talking of health research, pandemic, it's quite a wide area. So I have tried to actually make it as brief as possible so that there could be room for questions later. If you look at the WHO data, the cases, new cases are actually quite, numbers don't matter. It is enough just to understand that the number of cases are quite high. That's high.
Dr. Nandini, if I could stop you for a second, I think we can't view your slides. Could you share these again, your PowerPoint presentation? So I think it would be very interesting if we can, get this perspective of healthcare research during pandemics, because I think it's a very important part of the response to a public health emergency, as we have seen during COVID-19 as well. So yes, great. We can see your slides now, Dr. Nandini.
Okay. So WHO data is there, but it is just a way of presentation. Everybody knows that there's a lot of calamity going on globally, and when you come to the Indian data, the active cases are actually what you see. The figures may appear to be big, but when you compare it to the population, the denominator, the percentage is actually coming down slowly. And the deaths also are coming down. This is mainly because we have been wading through, various plus and minuses, and it's several months gone now, so we are wiser now than what we were earlier. So if you look at the COVID-19 trials in the clinicaltrials.gov, it amounts to 3,849. And the EU register shows 352 as the registered trials. WHO registry is 2,661, and this is all as on 6th November. Cochrane registry, of course, is quite large. For the past 3 months, the collections have been 13,226. And in the clinical trial registry of India, we have 626 trials. So it just goes to show that there's a lot of importance being given to COVID over the non-COVID subjects. So before we go on to the research part, I would like to mention that we talked about disaster-related research, how the ethics committee procedure can take care of certain aspects. And this was actually a regional workshop where Amir also was there. And we had made a draft based on that. A part of that was actually included in the 2006 version of the Indian guidelines. And that actually got expanded further as a separate section in the 2017 version, which is a third revised guidelines. Now, because of the COVID hitting us right on the face, now we had experiences to go by. So taking cue from this particular section 12, another guideline was made especially for directing ethics committees how to actually review the proposals and what to look for. So although it was based on that, the new experiences that came in was taken care of in this national guidelines, which came out in March 2020. The main aspects which were covered were the statement of general principles, which were the same as it was in the main guidelines, and the general ethical issues which actually took extra precaution for certain aspects which are very, very relevant to the pandemic. And then ethical review procedures, it not only talked about COVID research, but also what you do with non-COVID research and what you do with ongoing projects in greater detail than what was given in the guidelines of 2017. So informed consent, of course, was a big issue and is a big issue. Even now, people are struggling whether to go by the written consent or to take a verbal consent. And many researchers are actually forgetting that even when you take oral consent, you need to document that. So what do you do with all the data that they present if you have not documented the informed consent, oral informed consent? How do you actually treat that data? These are things which are actually new normals which will have to be addressed in further expansion of these guidelines. Vulnerability, of course, is there. We talk about that, but in COVID situation, people are even more vulnerable than their vulnerability during normal times. So this also has been addressed there. Privacy, confidentiality is the most important aspect whenever it comes to pandemics, epidemics for that matter, because public health actually curtails some of your individual rights because you don't want this, especially in outbreaks and infection, you don't want it to actually spread. You want to curtail that limit. So in such circumstances, what will happen to the privacy? So what are the drug research areas in India? Drugs, of course, research areas. There on drugs, vaccines, diagnostics, social behavioral and epidemiological studies. So if you actually break down the 626 projects which are actually registered in the clinical trial registry, let me also tell you that this registry is actually mandatory for all. So when you actually in India, the COVID research is supposed to be registered in the clinical trial registry. Otherwise, the clinical trial registry is mandatory only for the drug trials which come under the purview of the Drug Controller of India. And the others are actually on voluntary basis. But in the context of COVID research, it has to be entered into the registry. So we have interventional studies 363 and observational studies 261. Of them, you also have the studies using the traditional medical systems, what we call Ayush, that is Ayurveda, Yoga, Naturopathy, Unani, Siddha, and Sova Rigpa, which is Tibetan in origin, and also homeopathy. So, but actually, naturally, you find that number of proposals are more on Ayurveda. And many of these actually studies are on prophylactic aspects and a few on therapeutic aspects. So in India, there's a plethora of trials, of which some of them were actually initiated by ICMR also, like solidarity trials, placid trial, vaccine trials. Now there's talk about equine-derived antibody trial, epidemiological studies, COVID registry for COVID positive pregnant women, and otherwise also a COVID registry, and socio-behavioral studies, and stem cell trial, which is just in the pipeline right now, will be initiated very shortly. So what are the vaccine candidates? You can have a number of platforms there, using either attenuated virus, replicating viral carriers, non-replicating viral carriers, DNA, RNA, and protein. The safest bet is about using attenuated virus or protein. And what we have right now in India is the clinical trials reaching this phase 2 is with Covaxin, Zycov-D, and the AstraZeneca and Serum Institute of India, the Covishield. In fact, the Serum Institute of India, after the phases are over, it is expected to produce the intervention to such an extent that besides the domestic usage, it will also be able to supply for global needs. So these are actually some of the vaccines that are actually currently being used in India for being experimented in India. But although the number is slated as 30, these are the ones which are the prominent ones. And then we also have the diagnostics. So research has shown that instead of nasopharyngeal and oral swabs, you can have salival swabs, which give equally effective results. And of course, RT-PCR is supposed to be a standard testing, but because it takes a lot of time, more stress is being given to antigen testing. And now, people are actually in a hurry to bring out, test kits which will give you a faster turnaround time. So technological developments have happened, and so that it can be used in district and primary health centers, and you get the results in 30 to 60 minutes. The latest to enter the scene is the Feluda rapid paper test. And the Feluda is actually, many of you may be knowing about Satyajit Ray, and it is a detective in his narration, but here it actually means FN-Cas9 Editor Limited Uniform Detection Assay. And this is actually being looked at with great expectation. Supposed to be sensitive. It's done with the done in an Indian institution, science institution, and then it has been taken up by the industry for production. So while talking of all this, what I have not actually highlighted is what even Nida had mentioned, and Bushara also mentioned, certain aspects which are actually common in India also, especially during lockdown periods. It was very difficult to reach the medicines in research studies to keep the supply ongoing so that the research is not disrupted in between. There were also problems with the investigations that had to be done for simple X-ray testing that had to be done during follow-up could not be done. One, because the patients were afraid to go to hospitals thinking that they might get COVID. Two, because the facility itself was closed down. So some of these pharma industry actually made some innovative moments, like asking the patients to go to some local facility nearby. But the fear that was there that you will get COVID was actually a deterrent. So it was suggested that you go to a place for follow-up, which is convenient to the person. So alternate places where the researchers were supposed to go and follow them up. These were actually the innovative methods that were actually used, and then they were middle. Some people who were actually recruited mainly to continue the supply of drugs to these sites, because there were questions like the researchers saying that I can't get my milk supplies to give it to my children. How do you expect me to give medicines to these people because of the lockdown and the inability to get the transport to reach to the patient? So it is now the pharma industry is more interested in having electronic control. So more and more stress is being laid on e-consents and also getting the report forms through electronic media rather than doing it physically. So these are the general hurdles that are actually, it's world over, it's the same problem that is happening, but this is the way in India things were done. With that, I wish to thank once again the organizers for giving me this opportunity to talk.
Thank you so much, Dr. Nandini, for such a good overview of the diagnostic, preventive and therapeutic research that has been happening across India. I think in the panel discussion, we would really like to know how research regulation and oversight was, was it changed in any way during this pandemic in India? And this is, something that Dr. Saima would also go through in some detail in her presentation later. Professor Richard Sullivan has joined us now. He had some connectivity issues, and he's literally standing in the middle of a field right now. And because we would love to hear from him, so I would switch the sequence a little bit, and I would next go on to him. Professor Richard Sullivan is a professor of cancer and global health at King's College London, and the director of Institute of Cancer Policy and co-director of Conflict and Health Research Group. And his research group studies health systems, particularly NCD policy and the impact of conflict on health. He is an NCD advisor to the WHO, civil military advisor to Save the Children, and a member of the National Cancer Grid of India. His research focuses on global cancer policy and planning and health systems strengthening, particularly conflict ecosystems. So, Professor Richard, we realize that you're facing connectivity issues. So we would move quickly over to you, and we would love to hear your take on these aspects as well. Thank you.
Of course, Dr. Hassan, thank you so much. And good morning, ladies and gentlemen. It's wonderful to be with you. And thank you so much for this invitation. I have to say, this is the most unique setting I've ever had for giving a talk. I'm not joking. I'm literally surrounded by a herd of cows at the moment. I live in the middle of the Hampshire countryside, if any of you know the United Kingdom, and it's infamous for its terrible signal. We've had massive short-outs and electricity problems. But the good news about this talk, of course, is going to be a PowerPoint-free talk, which I'm sure you'll all be able to sort of relax over. But I do promise I will send, because I've got some interesting references, so I will give Dr. Hassan my presentation, and I'm sure she'll be able to share it with all of you, so you'll actually be able to look into the references in more detail. So I was kindly asked to talk about the impact on cancer more globally, and in the sense the work we've been doing on what we've picked up in the interface between the biosecurity issues of COVID-19 and the way we've been caring for our cancer patients. I'm going to start by just sort of laying out what I'm going to talk about. I just want to talk more generally about pandemics and NCDs and cancer in particular. And then I'm going to focus really on three broad areas. The first broad area really comes down to the issues that have evolved around the risk to patients and staff from the virus itself as we've evolved through the pandemic from February, March onwards. Secondly, the indirect impacts due to what was being called the NPIs, non-pharmaceutical interventions, i.e. the lockdowns, on cancer care and indeed on cancer outcomes. And then I want to end up more on maybe a positive note and talk about the silver linings that are starting to emerge. In other words, how our systems can be strengthened in light of what's happened to us from the COVID-19 pandemic. Because it's fair to say that overall the pandemic has really exposed all the weaknesses and strengths of our systems. In terms of the strengths, it's really exposed the strengths of the individuals working in hospitals who have been marvelously creative around the world in terms of actually keeping patient care going as best they can, coming up with new regimens and new approaches. The flaws it's exposed many flaws, particularly around the fragmentation of our systems. I think it's exposed deep flaws in our vital statistics and cancer information systems. And it's exposed, I think, flaws in terms of our ability to share information with each other, particularly, and I'm going to focus now really on the risk factors. So let me begin with, should we have been surprised and why was no one really prepared? It's remarkable that we've had over nearly 1,000 pandemics and epidemics over the last 10 years. People will be, of course, very well aware of the other coronavirus pandemics such as SARS-1 and also MERS as well, which broke out in the Middle East. MERS in particular was particularly unpleasant. Nearly 80% of people contracting MERS, which originated in camels, ended up in ITU, and it had a case fatality rate of nearly 30%. So it's remarkable that we weren't better prepared, and indeed a very interesting piece of work that was done looking at the Global Health Security Index in terms of ranking countries around their pandemic preparedness has basically shown that was a complete myth. There is no relationship between your level of preparedness on that index and how well you actually did. So when the pandemic struck, I think it's quite clear that no one really understood how seriously exposed our cancer patients were. And indeed, was there anything different about our cancer patients beyond age and the comorbidities, which emerged very quickly out of the studies that were coming out from Wuhan? And I think it's fair to say we had to focus very much, and we were mostly working in the dark. Nearly any data we were using to treat our patients was coming out from the Chinese studies that we've been published in TLO and other sorts of journals. So in the early days, we did have a lot of difficulty trying to ascertain what was safe and what wasn't. And indeed, we now know, of course, the infection fatality rate is between 0.3 and 0.4. But I think it's fair to say in the early days, we were extremely concerned about this. A lot of patients had their treatment heavily delayed. A lot, particularly in the West, had treatments cancelled, particularly around surgery. Diagnostic services shut down across the board very quickly. Screening services as well. We saw a huge decline in screening services. And it wasn't really until probably March and April did we start seeing improvements in terms of ability to treat people and bring them back into hospitals. And I think one of the telling things is talking to people across the world, and we've got this COVID-19 and Cancer Task Force, of which the centre is a part of. And what we've noticed is it was very heterogeneous. Everybody was having to make things up as they were going along. In some centres, business almost continued as normal. In other centres, literally all services shut down. So we have this incredible heterogeneity. The other heterogeneity we saw was, of course, the differences in treatments. A lot of patients on treatments were very concerned about immunosuppression. And so what we saw is a lot of dose de-escalation of people on chemotherapy. We saw a lot of dose de-escalation of fractionation regimes for radiotherapy. But when we've actually looked at the data, there is literally no rhyme or reason why some people did X and other people's did Y. And I think one of the interesting things now, going forward, we were going to have to look back very carefully to see what regimens and what approaches we took and what impact that's actually had on patients. But I think it's one of the major learnings. I think by the middle of next year, end of next year, it's going to be important to have sort of honest audits about how treatment regimens changed and what impact they actually had on patients. One of the things we also weren't prepared for is the risk to our staff. Many staff got sick, We got rapidly sick. We had staff as well who died as well, particularly those elderly with comorbid. And we had a lot of staff that had to be sent home because they'd come in contact with people who got COVID-19. So we saw huge staff declines. Staff, of course, as Dr. Nandini also mentioned, I think just briefly, weren't able to get into work because of the lockdowns, and staff were redeployed for the COVID-19 patients. And so the levels of human resources we had to treat cancer patients went down. But again, huge heterogeneity depending on which centers you were looking at around the world. Let me just move on now to the indirect impacts. Very quickly, a lot of countries started to introduce what we consider to be lockdowns. And it wasn't just lockdowns in terms of the societal lockdowns. It was extremely hard messaging to the public to stay at home, no exceptions. And what we've seen around the world was a huge decline in patients presenting with their cancer. Now, a lot of this, of course, now has recovered in many countries. So we're seeing recoveries really across the board. And it's interesting, and maybe we'll talk about the second wave and whether we've learned anything from the first wave. But nevertheless, across countries, we saw between 10 and 85% decrease in incident cases appearing at cancer centers. And we published a paper in the Lancet Oncology just looking at England and looking at 4 cancers to see what the impact of diagnostic delays was going to be on outcomes. And what we found was essentially this was going to lead to between 3 and 3,500 excess deaths, which equated to, wait for this, 65 to 70,000 years of lost life, because the patients dying, of course, are much, much younger. And I've just noticed there's a comment about not being able to see the slide presentation. I'm sorry if you just joined. There isn't a slide presentation. I'm just standing in the middle of the field, but I will send the slides around. So this was a huge, huge impact. In many countries, we don't have that data, but that sort of modeling data really needs to be put forward, because I think one of the things we've noticed with the pandemic is nearly all the policies are being driven entirely around COVID response. They're not taking into account the indirect impacts of lockdowns. The other thing we saw was, and it's not just simply diagnostic delays, is a lot of patients during this time suffered enormously in terms of palliative care and end of life. This is something I think we all know about, but hasn't been really quantified, is a lot of patients died alone in hospital. A lot of patients died in care homes and at homes without proper palliative care in terms of pain relief. And I think this is one of those sort of aspects of what's happened in terms of the lockdowns that people really haven't talked about much. We've talked about delays in diagnosis. We've talked about delays in treatment. We haven't talked about the morbidity, the suffering that's occurred to our cancer patients. I can tell you now, we've just published in the BMJ a big meta-analysis on the impact of delays of treatment. That's well worth going and having a look at, because what it essentially says, in delays in treatment, there is no safe delay in treatment. Basically, for a 4-week delay in any type of treatment, surgical, radiotherapy, or chemotherapy, you're looking at about a 10% increase in mortality, which increases at 8 and 12 weeks proportionally. That is a big, big impact. So the indirect impact from lockdowns has really serious consequences. And I think it's one of those things, I think for generally countries are going to have to really work out what that means, because I think future waves, there has to be a balancing act between the degree of lockdown and the impact of non-COVID health services and indeed on long-term welfare. And one of the slides I had here to show you was also to talk about the long-term impact of declines in GDP on cancer mortality. What we're basically seeing now is huge declines in gross domestic product across the world. So the economic impact is going to be huge. It varies between about 3 and 12%, depending on which country you're in. We know from work we did with Rifat Atun many years ago that declines in GDP equal declines in total health expenditure and leads to, in the long term, declines in increases in cancer mortality. So that's something else that has to be taken into the equation that we're also very sensitive of. So that's the aspects around the indirect impacts I just wanted to sort of briefly mention. What about the silver linings? So the COVID-19 and Cancer Task Force is looking at silver linings. I think one of the silver linings is going to be a much better focus on health systems. I think our health systems have to improve. I think there'll be more money available to improve them, both vital statistics and our cancer information systems. And I think we'll find ways of better sharing early data. So, for example, if a new pandemic arrives in Pakistan and you have early experience of what it means for your cancer patients, other countries can rapidly learn from it, and vice versa. So I think it'll improve both the direct formal and indirect informal relationships to share data very, very quickly. And I think that will be a huge bonus. The other silver linings, I think, as well, was we did overdo it with bringing patients into hospital. We could do a lot of work in telemedicine in the sense of actually talking to people by phone or having engagements over Zoom with them. I'm not saying that is the great panacea that everyone says it is. It's not the silver bullet. You still need to see your cancer patients in outpatients. There are lots of procedures that do need to be done in hospitals. But I think we overdid it. It was very expensive bringing people constantly in for outpatients. So I think we still will see, I wouldn't say a macro revolution, but a micro revolution in the way we use telemedicine to engage our patients. But the caveat there I want to make is, first of all, there are many countries around the world that don't have good connectivity. And it's comedic. I'm talking to you in the middle of a field, really, talking about connectivity and doing telemedicine with patients. That's number one. And number two is to say that, of course, it depends on the user. We have many elderly, frail patients who simply find it very difficult to use the phone, find it very difficult to engage on Zoom. And also, I'm going to be honest with you, it loses the personal touch. There's something, I don't know how to explain this, you all know it. You're all doctors, you know, it's different when you have the Mark 1 eyeball and you're looking at a patient in your clinic. You can tell whether he or she is sick or not, whether they're getting better, whether they're stable. It's very hard over the phone or over Zoom to make that assessment. And I think that's going to be the ultimate thing, is we are, as human beings, social animals. But nevertheless, I think that will improve dramatically some of our care and pathways. And finally, to say, I think it's going to make us realize that we do need to deliver progressive universalism for cancer care. We're going to see declines in survival. We're going to see increases in mortality across the board. And I think this is going to really shake up our policymakers in terms of improving funding into cancer, improving funding into global cancer, and making people realize we really need to focus over the next 20 years on the next pandemic, which frankly is the cancer pandemic hitting countries. So I think this will help in terms of our policy objectives overall. So at that point, Dr. Hassan, thank you very much. I will pause and stop there. And thank you so much for this invitation today.
Thank you so much, Professor Sullivan. I think you have made some excellent points, and we are really grateful that you were so effective even while standing in the middle of cows in a field. I think that the ground realities that you have shared also bring home the point that this pandemic has seen that the divide between the lower middle income countries and higher income countries has actually shrunken in a sense, because we are all in this together, and the challenges that we have all faced are not as different as they are usually in our routine settings. You've also highlighted the importance of looking back and reflecting on what we have learned in last 6 months, 6 to 8 months. And I think that one of the key things is to pause and reflect and review whatever was done in these 8 months. We all know that this has been a very hit and trial kind of a thing that everyone has adopted in various settings. But it's important that we are not as clueless moving forward as we move into the second wave, and we don't know of the number of waves that will hit us next year as well. So I think there are many interesting points that have been raised in your presentation. I hope you stay connected, because it's really important that you stay with us in the discussion as well.
Okay.
For now, what I'll do is that I'll move to the next presentation. Again, there are some interesting questions here that have come up in the Q&A box. We'll reserve these for the panel discussion. And I'll move to Professor Saima Iqbal. She's a professor of family medicine at Shifa International Hospital, and she's also the chair of the National Ethics Review Committee in Pakistan, and somebody who has been extensively involved in COVID-19 research review during this year. Dr. Saima, over to you, and we look forward to hearing from you.
Okay, thank you very much. Assalamu alaikum and good morning, good afternoon to all the participants according to your respective time zones. I'll be presenting, our experience with the national level review process in the last 9 months. And the outline of my talk will just talk about what we, the National Bioethics Committee, does. And we are part of all the Research Ethics Committee, how we function on a normal basis. A brief touch upon about the rapid turnaround review process that we developed in wake of COVID protocols. I'll touch upon the challenges while reviewing projects and some of the challenges which occurred after we had approved these projects. I'll give you some examples of high-profile trials that have occurred in Pakistan and what we as a national body have learned, and some things for us to go on from here for our future scientists or all those who want to present their research to for review. So you can see here we are a Gazette notified advisory body. We got established in 2004. We have two main functions, the Healthcare Ethics Committee and the Research Ethics Committee. We have ex officio members and we have elected members. Our members are basically from the Higher Education Commission, the Pakistan Medical Commission, Drug Regulatory Authority of Pakistan, Nursing Council, Islamic Ideology Council, and so on. So this is a diagrammatic representation of the NBC. We are aided by the NBC Secretariat, which has the Healthcare Ethics Committee and the Research Ethics Committee. So what sort of researches do we review? So any research which has international funding or any research which has been funded by the government of Pakistan, or any research which is done in a multi-province, more than one province of Pakistan, any drug trials which need to be registered are reviewed by the NBC REC. So in wake of the COVID-19 emergency response, the REC developed its TORs. We got our first case end of February, so we were prepared that we're going to receive an onslaught of research reviews. So the Secretariat and the REC members, we met virtually on Zoom to develop our rapid turnaround review TORs. These were prepared according to the WHO guidance document about rapid research ethics review during disasters. So this is a diagrammatic representation of how we look at the research reviews. We receive soft copies by the NBC Secretariat, and then these are forwarded to the chairperson and then to the rest of the REC members. And, generally we used to have a 6-week turnaround review for proposals, but in the COVID pandemic, we underwent the rapid turnaround reviews within 72 hours. So we respond to the PI with their review after reviewing. We usually the REC would meet on the using the Zoom application, and timing was always a challenge. So with the passage of time, we realized the best time suitable for most of us is around 10 p.m. at night. So some of the challenges that we've had during review. First of all, there were issues with science. one of the major problems that we faced. We've had issues with media publicity and hype, and I'll give you one example of the convalescent plasma trial later on, how we dealt with that. Then we had some unrecognized molecules or drugs as potential therapies for COVID. These included some Chinese medicines or nutraceuticals. So, because scientists were rushing to make written protocols, they were hurriedly written, they were not relevant details were not given. Rationale quite often was not well defined. Many projects we felt were COVIDized, to make it relevant to the times. Study designs were quite often not very well designed, very poorly designed. There was no specific inclusion-exclusion criteria. We gave a lot of attention to the research team, and we were not aware of the research people that were included in this study. We pay particular attention to the informed consent form. So if the informed consent form, we were careful to make sure that they were not giving any misleading information to research participants. And quite often when we were unable to understand the science, we co-opted experts to help in the review process. So some of the challenges that occurred after review, we've had some changes in recruitment strategies and altered methodology. We've had some arms, like for example, in the Solidarity trial, which had to be halted. We have come to know about expansion of the research to different sites. And I'll give you an example later on about the convalescent plasma trial and the Actemra trial. And quite often follow-up reports were not available and the REC Secretariat had to pursue the PI to give us some sort of interim reports. So we had to go after them. So this is one of the earliest trials that we had approved. The convalescent plasma trial, there was a lot of media hype and public engagement prior to it being reviewed by the REC. There were obvious deviations from the protocol. The interim results that we had asked were not satisfactorily presented. But unfortunately, it got so much hype in the media that public appeals for plasma donations began to come on social media, so much so that healthcare professionals started to make requests to make plasma donation mandatory. And there was a black market had developed for plasma, and there was exchange of money between plasma donor and recipient. Only after when, world over, it was determined that there is not much difference, significant change in morbidity or mortality did the hype die down. Another trial that we had approved was the tocilizumab trial. We had approved one site for this, but without knowledge to the NBC REC, other sites also became part of the trial. And Actemra became a standard of care in our national guidelines without the scientific evidence. And so much so that healthcare professionals and general practitioners started to prescribe tocilizumab for mild COVID patients. So this is the latest, the CanSino vaccine trial, of which it's a phase 3 double-blind placebo-controlled trial. Several centers in Pakistan, including Shaukat Khanum, are also involved in this trial. So advertisement for this trial has potential for therapeutic misconception. Community engagement is a challenge, and one of the concerns that the REC has been showing that any compensation being offered to trial participants should not become an inducement. And this is one example of how this trial was advertised. And for those of you who can't understand Urdu, it roughly translates into saying, get yourself vaccinated against coronavirus and protect yourself. So again, this we thought was giving wrong information. It was not highlighting that this is a research going on. So the REC raised its voice and had this poster withdrawn. So some of the lessons that we've learned is that, you know, the science, you can't compromise on the science. So one has to strengthen the science, make sure that whatever your trial, whatever your study design should have a good rationale, and be very particular about how you're going to implement this study. Scientists also need to show some sort of responsibility, and while interacting with media, because you know, in a pandemic situation, panic escalates, and that leads to a lot of misinformation. And of course, you know, I think one of the major challenges that we've had was to withstand political pressures. Since we are an advisory body, I think the REC has been, you know, very good in withstanding the pressures as much as it can, based on the amount of scientific evidence that has been generated. So I will stop my presentation here, and if any questions, I'll be happy to take them.
Thank you so much, Dr. Saima, for a wonderful presentation. I think you've given us a great overview of what happened in Pakistan in these last few months. I think and you know, I guess it's my researcher bias here that I think that we'll start our panel discussion with a discussion on the research aspect. And also because I think that it needs to be, it cannot be highlighted enough that research has been an integral part of the, you know, of the global response to this pandemic. You know, the same set of principles that were applied to healthcare, which were to, you know, try and test everything and anything, were also forced onto research as well. And I think that that had a negative impact on the credibility and the transparency of that research globally, not just in Pakistan. I think that, and I read this somewhere a couple of days ago, that the warlike analogy that is being used for COVID-19 has actually had a very you know, negative impact on the value system of decision making in this pandemic. Because, you know, as they say, all is fair in love and war. So I think that it was considered that, you know, anything and everything goes for both healthcare and research during this pandemic. Now that we have had some time, I think it's important to reflect, and I hope that this session contributes to that reflection. So starting off with you know, my first comment, because a common theme in all the presentations has been about you know, the importance of community engagement. And I think Dr. Saima has also wonderfully highlighted how this engagement could, you know, go south as well, how this engagement could be used negatively as well. So if I could get a brief comments from all our wonderful speakers here on what they think has been the situation of community engagement or its impact, especially for research. Professor Nandini and Professor Saima, if you guys could share your opinions, and then I'll take a brief comment from Francis and Professor Richard as well. So we'll start with Professor Saima first. So, you know, what's your take on community engagement during this pandemic, especially for research?
Okay, thank you, Mariam. I think community engagement, again, has to be done responsibly and honestly as much as possible. You need to understand we live in a hierarchical society. Doctors' words are taken as, you know, in the best interest. People generally do trust doctors, and they think that if doctors are meaning something, they mean it for our betterment. so one has to be upfront. I think, and what I can tell you about the vaccine trial, the PI of these trials, at least in the organization that I work in, they have been targeting young people who are educated, again, encouraging them to come and ask questions. So it's one has to be very careful with community engagement. You have to keep in mind your target audience, who you are talking to, and make sure that no wrong information goes. So the young people, they're enthusiastic, but they tend to ask questions a lot, and the young people ask honest questions. So I think that should be encouraged. So that's what I can say, that from our perspective.
So if I can move to Professor Nandini. Professor Nandini, what has been the environment of community engagement in India? We share a culture, and our cultures are quite similar. So if I can take the liberty of saying that our population structures are quite similar as well. The issues of hierarchy that Dr. Saima mentioned is also something that is not just unique to Pakistan. India is also a hierarchical society. So, in a pandemic, while you are negotiating with rapidly emerging evidence, how do you ensure that an honest communication or a dialogue with the public is, done when we are so unsure of everything ourselves? How has India tackled this problem, or how has India been unable to tackle this problem like us?
See, on one hand, it is unsureness. On second hand, it is misinformation. Both these are actually playing havoc. And initially, when people were going for surveillance, they were, beaten up. People from top of the building were throwing stones at them, all because they were not prepared. So there was not this awareness among them that this was for their own good. And initially, in the what you call the panic that had come up, people being locked up and put in quarantine and all those things. So all sorts of rumors were making their round. They didn't want to go into quarantine. They didn't want. The general statement was that we are taken somewhere, and our family will not know anything as to what is happening to us. So that was the initial reaction which had happened. Then over the months, because of the ads, the government ads, and people, local level people were actually educating them. So this resentment came down a little bit. But then there's also this, what you call, the tension between the two systems, the modern medicine as well as the traditional systems of medicine. So there were some claims made which were not appropriate, actually. It was not from the government, but a private section. So again, the ire expressed for those results were generally reflecting on the other systems which were following the norms. So these were some of the difficulties there, but things are settling down. But still we have some activist groups which oppose everything, because everything is political these days, one political system opposing the other political system, which is in the throne, I must say, for the time being. So these tensions are all there, but people who are reasonable are trying to make some meaning out of it, and some results are there, of course.
That's good to hear. I think that, again, Dr. Nandini's comment highlights another comment that Dr. Nida had made in her presentation as well, which was the issue of confluence of science and politics in an era where we are just surrounded by so much mistrust. And I think that this has had a big impact on how both the non-pharmaceutical interventions uptake by the public, as well as their trust on the research endeavors as well. Here, I think I would, I would like to get some comments from Francis, and I would, it's my privilege to introduce Francis here as well. So Francis P. Corley is the Executive Director of the Good Clinical Practice Alliance in Belgium. He's the founder and director of the Strategic Initiative for Developing Capacity in Ethical Review. And he also is the coordinator for this GCPS. It's a European Fellowship in Research Ethics. He's a philosopher specialized in ethical, legal, and regulatory issues in health research, having taught at several European, Asian, and Middle Eastern universities. And I think the most important part of his introduction is that he was the director for the fellowship that I was fortunate enough to attend in 2018. And which was a life-changing experience for not just me, but for all those who attended that fellowship. Francis is somebody who has changed lives, and I think during this pandemic, he was only Zooming and doing nothing else. And he has been instrumental in, he has been one of the key factors in ensuring global collaboration in this time. So Francis, could you, because we talked a lot about preparedness and learning from what we have done in the last 6 months. And since you're a big part of the initiative on preparedness, could you introduce us to that initiative a little bit, and what has been your experience? Because you are somebody who has had a truly global overview of things during the last 8 to 9 months.
Yep. Thank you, Dr. Mariam, and thank you for those nice and undeserved words. I think it's been a fantastic webinar so far. I think really enlightening and a lot of learning coming from each of the presenters. Of course, I think like all of you, I'm most jealous of Richard and the good company he has this morning in the Hampshire countryside. But yeah, I want to say that this webinar to me is a good representation of the kinds of discussion that we see going on around the world and the complexity of the discussion. One of the things that the COVID has done is shown us how intertwined we are. Not only, let's say, in the global sense or in the sense of different countries and different populations and how much we depend on each other, let's say, for our healthcare and for the data and things like that, for the research, but it also shows us how intertwined we are in a certain kind of very basic level of connectedness. So I think this discussion here on communities is really important, because really what we've been doing, and Dr. Mariam and others and I have been doing over the past few, we have a small community looking at how we can prepare ourselves for pandemics and how we should respond to COVID. And it's really a community engagement across everything. When we talk about public health, and it's really about the public that makes the health possible. And that's what we're seeing in the COVID pandemic. We're really seeing everywhere the importance of community, or the importance of public in participating in this. So I think the other thing that we always tend to see from, let's say, the point of view of Europe or the point of view of the US, as community engagement being something that you do in Africa or in Asia or Latin America or something like that. But really what we're seeing now in Europe and in the US and other places is that the community and how we address the community and engage the community in the public health is really important. So I think we're all in this kind of community together. We have our individual instances of community, we have our individual representations of community, but public health is a community engagement. It's really a community engagement. It's what makes it possible. It's not just government, it's just not money, it's just not research or institutions, but it's really how the public itself engages it. I think what Dr. Nandini just said now about the response in India, this kind of learning that the public goes through, the role of the government, the role of the researchers, the role or what Professor Simon, I think, just said about the role of the young people and how you reach out to them. And we have to do this everywhere. We have to do this in Belgium. Richard has to do it in the UK. Somebody's going to have to do it in the US. It has to be done everywhere. We have to engage the public in order to really address this. A pandemic is not just a disease. It's a public issue, and it affects all of our lives. Just to say, we started out, Dr. Mariam and I, we started out several months ago doing one webinar and then thinking, oh, we'll write some guidelines. The kinds of guidelines that Dr. Nandini or Professor Simon have already written in India and in Pakistan for that. And we found ourselves doing more webinars because the problem gets deeper and deeper. It's more spread out. It's not just a disease. It's not just a virus. It's not just a matter of finding a therapeutic or a good diagnostic or what we all hope and pray will save us, a vaccine. That's not what COVID is. COVID is a public emergency where health is in the center of it. Those are some thoughts.
Okay, so great thoughts, Francis. I think that one of the things that that preparedness planning discussions focus a lot on is to have guidance. And since the focus of our discussion today has also been about policy making, and both Dr. Saima and Dr. Nida and Dr. Nandini have shared, policy making that was done for various decision making during COVID-19 at their respective places. We had a very interesting comment to policy making by Professor Bushra Shirazi earlier, where she was a bit wary of the disconnect between making a policy and dealing with the ground realities. Now that we have Professor Richard Sullivan with us as well, can I take comments from both of you, Dr. Bushra and Dr. Richard, on how helpful you think policy making can be in ensuring equity and transparency and the values that we wish to uphold even during something as disastrous as a pandemic. So Professor Bushra, I'll go to you first and then I'll request Dr. Richard to give us his take on this.
All right, so thanks, Mariam. As one says, I said that because I actually meant what I was saying. And I think when I'm listening to the whole group discussion that's going on, I find it very, it lays emphasis on one major thing, and that's looking at healthcare infrastructure as a whole. So when we are looking at healthcare infrastructure, you can see it at an institutional level or as a nationwide issue where from basic healthcare policies in an institute get further highlighted in a disaster situation. And in this case, we're talking about a pandemic, right? Now, when you are looking at that, there appears that there is no connection between these isolated islands of healthcare within a country. And that, in my opinion, is the problem that we face for whether it's community engagement, whether it's the healthcare practitioner at any level, or whether it is the researcher. There doesn't appear to be a bridging angle or a bridging unit, because each one in themselves are working and trying to improve, and whatever their benchmark is, they're trying to go one up on it. However, the bridging capacity does not seem to be highlighted in any forum. So I would reinforce in saying that the infrastructure in itself, and this sounds like completely, it's wishful thinking, but who is the person who's going to bridge these aspects together? Research is a very integral part of how medicine is going to progress. However, how does research translate in a community where literacy is less than 50%, right? In a community where empowerment is completely at a level where vulnerability, as one of our speakers said, they're just more vulnerable in this time of pandemic. How are people going to address this? It is all fine and dandy when a group is sitting down and raising issues that are very valid, very contextual and apt. But which is the body, or whom should the body be that creates the bridges between, everyone? So I think I feel that's a concern. And I feel it's a concern that everyone has to start collaboration at some point and move a little bit out of their islands and say, okay, let's share and see what can be done. And at one point, I thought Professor Sullivan and even Mr. Crawley was referring towards it in different ways. So I do believe that would be the way forward. So if someone, and I can tell you that's not the job of the clinician. I don't even think it's the job of the individual researcher to do that. But someone really needs to take it if we want to avoid something like this happening again. So that would be, I'll hand over to Professor Sullivan now.
Thank you very much. I can completely concur with those comments. Maybe let me give you an analogy of what it felt like to begin with. It felt like dropping a plate on the floor. The plate it was the sort of the system and the fact the way we all work together, and we dropped the plate on, everything shattered. What we saw was a complete disconnect between high level policy making and what was actually happening at the hospital level. So even within hospitals, we saw individual disease management groups doing their own things as everybody struggled to catch up with the rapidly developing kinetics of the pandemic. There were exceptions. I think there are different examples in different countries of where different communities were much more coordinated. I particularly like to point out radiation oncology. I've been actually quite impressed looking around different countries about the speed in which the radiation oncologists started working together to work out how to do more homogenous approaches to treating patients. But I completely agree as well with the research aspects. We saw a lot of what I would call knee-jerk reactions of research being just simply shut down, trial recruitment being shut down, without thinking what was this going to mean for the patients. You can imagine a patient in a phase 1 trial suddenly being told, I'm so sorry, we're finishing your trial here. Now for these patients in phase 1 trials, this is their last chance. But even for patients in major trials, for instance, in neoadjuvant or adjuvant setting trials, those trials were shut down as well. We don't know how many of them we'll be able to restart now. And I think one of the issues exposed, as you said before, is this disconnection between the very high level policy making and the speed in which we were able to react at the ground level in terms of the hospitals. And I just want to segue as well into this issue of public trust as well. It's a conversation I often have with my colleagues at the National Cancer Grid in India, which is the fact that patients have also come to us being exposed day in, day out to media information about the pandemic and the risk to them. And we see a huge amount of misinformation in our media in the UK about safety, risk, and I'm constantly seeing patients coming in with cuttings from patients saying, is this a risk? Is this a risk for me? And so there's been an incredible amount of noise that patients are being exposed to, even when they're not in the hospital, which is, I think, altering the way they're behaving towards research and the way they're behaving towards coming in for their care as well. So there's this very complex interface between policy making, the media reporting of their risk, in this milieu that's being mixed up together. But I think generally, just to pick up the last point, what's helped us enormously is being able to have these conversations with other colleagues across the world. in order to try and find out a sort of, a happy medium to treating patients and trying to get our research restarted. But again, I think these have all been done as informal networks rather than any form of formal concerted effort to address this. Thank you.
Thank you so much, Professor Richard. I think that all comments are really highlighting the importance of sharing and communication and collaboration to have a truly unified response for both healthcare, for global health issues, as well as for research during a pandemic. Because all of these things ideally should go hand in hand, and they didn't. And as we have seen in the presentation by Professor Richard as well, this has led to an impact on morbidity as well as mortality, and this is something that we will continue to see in the months to come. So perhaps this is something that should be the focus of all our efforts moving forward. And I guess that we have also highlighted that the importance of community engagement at the policy making level as well, because you cannot make a policy and thrust it onto a public that already does not trust you. There was a very interesting comment, a question in this session from one of the attendees, and I think it links with the discussion at this point. So I will take this up right now, where one of the attendees had posted that we had mentioned culture as a challenge, but interestingly, we also saw the countries where principles of liberty and freedom are entrenched, for example, Europe and US. Their populations had more difficulties in accepting lockdowns and restrictions. Perhaps it is not merely about our culture, but also about human behavior in general that makes it challenging to enforce SOPs. So we have to figure out a way to enforce guidelines. I know that I can take the liberty of guessing that this panel of experts would not agree to enforcing anything. But I guess that if I can, get some comment on this from Dr. Nida on, what's her take on the impact of culture on all of this.
A very interesting question, and your guess is absolutely right. So the problem is that it is because I also, my other hat is of teaching organizational ethics. So I call it the approach of us and them. So when you talk about patient and the community as them, and you consider yourself as us, this is a common way of looking at at things. I think the solution that is coming out very clearly in this webinar is engagement of community. So the way the community is behaving is what community is not different from us. It's not anything different from what healthcare professional is. So if you want to know what community wants, you have to make them part of the discussion. So whatever is coming out at different levels, whether it is a hospital, it's the hospital ethics committee, or a district hospital where or a district where there is some form of structure for provision of healthcare. If you have communities part of the whole dialogue, properly engagement will not be that difficult. There will always be outliers, there will always be deniers, and there will always be people who would not be engaging with it. But can you enforce it onto them? So I don't see any other possible solution but dialogue. So dialogue with all those who agree and disagree is the answer to it. That's how I look at it.
Okay, thank you. I think an important point that you made was the issue of us versus them. I think this pandemic, at least in Pakistan, many of the discussions on social media platforms also made it like, there are healthcare providers who are dealing with all the risk, and then there is a public that is, completely, especially in the initial part of the pandemic when people were not accepting, the disease even, or any of the SOPs. And I think it created, in a sense, a disconnect between the two communities. So community essentially means all stakeholders. It also created a lot of unrest amongst healthcare providers because they were taking risky decisions. And I think a part of your presentation focused on, the guidelines emphasizing that healthcare workers should be indemnified when they make, healthcare decisions when faced with such uncertainty. So I was just wondering, Francis, there was a question in the Q&A chat box that raised the concern of operationalizing the indemnity issue. We know that healthcare decision making as well as research has been undertaken amidst great uncertainty, and there is a lot of talk about indemnifying physicians and perhaps even researchers who have undertaken research in that time. So in the global discussions by the PrEP group, have you come across what's the opinion on this, and what is your take on this, the issue of operationalization of indemnity, or whether or not this should even be offered to healthcare providers? Do you think this would lead to a lack of accountability altogether?
Well, I would say, firstly, Richard is going to be better placed to answer that question than me. Just from a helicopter viewpoint here, of course, indemnity is an insurance issue, so it's a kind of legal issue about how we protect our healthcare workers and allow them to be comfortable making decisions that they have to make. Also, for the ethics committee members, Dr. Nandini might be able to talk about that as well. But I would say something first before indemnity, and that goes back, is trust. So without trust, indemnity is not going to be such a great solution anyway. The first thing we have to do is create trust in the healthcare system and in the healthcare providers, because we don't want this, and I'll go back to what Professor Nita just said. We don't want this confrontation between us and them playing out in the social sphere or in the legal sphere. So this is what we really have to begin. We have to try to begin our discussion, as you said, Dr. Miriam, with all the stakeholders in an area of trust. But I think with regard to indemnity, there are people here are much better qualified to speak about it than me.
So, Dr. Neda, would you like to comment on this?
Indemnity is definitely a legal process and legal stature. That was one point that was being raised in the guideline, that indemnity was being mentioned in the guidelines. With it is with documentation and sharing the burden. So if you say an individual, if you let an individual physician take decision and say indemnify the person from whatever decision this person is taking, then it will become a problematic situation. But within the organization, the guidelines strongly recommended a structure for decision making, a sharing of the burden of decision making in a very difficult scenario. And when one decision is taken, then that decision should not be penalized per se, because it will be a difficult decision. It will be for that difficult time. It will be for that difficult moment. So indemnify clinicians from the decisions that are being taken in an organized manner. So yes, it will be it can lead to what we call it as a slippery slope if we just let individuals take decisions in their capacity and not question them, but have a structure to look at the decisions within the institution and then indemnify, in the sense that with the lack of trust within the community, if the decisions, whatever decisions are being taken, are being challenged again and again and are looked at with undue criticism, then it will actually worsen the level of trust that is already deficient within the society. So indemnify from that particular angle.
I think it would be great if we could hear from Professor Richard on this as well, because he mentioned that he has done, he has published a review of the impact and the outcome of treatment delays. Since we have, he has data that shows the impact of, the decisions that were taken amidst uncertainty and possibly their adverse outcome as well. What's your take on this, Professor Richard? Because obviously those institutions or healthcare providers who made those decisions of delays, these weren't exactly their decisions. They had to. They didn't have an option. So do you think patients would be right to hold them accountable?
Yes, thank you for that. It's been fascinating watch this unfold. Let me just first of all caveat what I'm about to say is that we talk about trust here. The trust within our healthcare providers in the United Kingdom is very high. In fact, all the surveys show it's probably the highest of any institution at the moment. Well, we don't have the trust. That there is a real lack of trust and confidence at the moment in the way that the pandemic per se is being handled by the British public. And again, we've seen this declining over time quite significantly. And this is really very multifactorial. It's about political behaviors during the pandemic. It's about the way the information on the pandemic has been put out, the failure to balance up risks proportionally. And that it's a long, complicated reason, but that's important because in a sense, it envelops everything about how we in the medical community operate, because obviously the trust and confidence really is around being able to deliver the right care in the right way. And we talked about indemnification. We're subject to something called the Bolam test, which is an interesting thing here because it's really the Bolam test is around clinical negligence and is reasonable behavior. And I think we've really struggled in terms of what has been reasonable to be delivered at hospital level during a pandemic under great uncertainty. And I think it's still going to be interesting. We've had no lawsuits yet in the UK about either delivering treatment which is being considered inappropriate or not delivering treatment. It's very unlikely we'll see that, but there's no doubt at some point somebody will raise this. So the indemnification is all there, but I think that we're still yet to see the impact on what the delays on diagnosis means. But I think in any lawsuit, it will be directed towards the government and the MPIs they put into place rather than against the National Health Service. Thank you.
Thank you so much, Professor Sullivan. I think that this has been a fascinating discussion. Unfortunately, we have not been able to cover research in the depth that I wish we could have. But I guess the plan was ambitious to begin with. And I think the points that have been covered have been great. We are coming to the last 1 minute of our session. I would like to thank all of you, especially for, dedicating a fraction of your Sunday for this session. I realize this requires huge commitment from all of you, especially Professor Richard, who is literally standing in the middle of cows at the moment for this. But thank you all so much, and it has been a fascinating discussion today. And I think that I'm sure our audience has enjoyed this as much as I have. So thank you so much.